Okay. Hello, everyone. Good morning, good evening, and good afternoon from wherever we are joining. And welcome to this new episode of a webinar series. This particular webinar series is on the health, economics, and policy in South Asia. And today, the inaugural session is by Dr. Sridhar Venkatapuram. And over to you, Ashmita, to introduce the speaker and to lead the talk.
Yes. Good evening, good morning, and good afternoon, everyone, joining in from different time zones. And today we have with us Dr. Sridhar Venkatapuram, and he is going to give us a talk about the interplay of the pandemic with economics and what really is different this time around. Dr. Sridhar is an academic practitioner in global and public health ethics/justice. He's an associate professor in global health and philosophy at King's College London and Deputy Director of King's College Health Institute. He has been at the forefront of public health ethics for over 25 years, starting in the early 90s as the first researcher at Human Rights Watch to focus directly on health-related human rights violations. He's known for helping establish the area of health justice philosophy for engaging with and advising public or global health practitioners and for amplifying ethical reasoning in public global health education, research, and practice. He has also been awarded numerous awards, research fellowships, and selected to prestigious professional organizations, commissions, and panels. He has worked with diverse health equity organizations such as Population Council, Doctors of the World, and the World Health Organization as well. Since the early 2020, he has been actively serving in various pandemic ethics advisory roles at the local and international levels. And he's also serving as ethics advisor for the BMA Medical Ethics Committee, the NHS London Ethics Advisory Committee, and is also a member of the World Health Organization COVID-19 Clinical Management or Treatment Guideline Development Group. Over to you, Professor Sridhar, and let's hear what you have to say.
Thank you very much, Asmita, and thank you very much, Arun. And so welcome to all of you, and thank you for making the time to join us today. I first want to thank you both, Arun and Asmita, for inviting me to give a talk, and to others who were involved. It's something that I've been looking forward to since I got the invitation. It's very rare that I speak to economists, and particularly South Asian economists. So you are my sort of group that I want to talk to the most, because usually it's public health people and philosophers that I talk to, and they already know everything that I'm going to tell them anyway. But I'm hoping that today you might find something interesting and new that you haven't seen. But also it's a group of people that I have long neglected, because I've been focusing very much on public health and philosophy and not enough on economists. And so today is a really good opportunity for me to present a story that hopefully that you will find interesting and engaging, but also motivate you to think about going forward, how to think about your work in economics, in the different kinds of economics that you do, and how we might influence that, or how I might influence that. So this kind of talk, from what I understand, is going to go for an hour. And so we're at the 10-minute mark. So what I'm going to try to do is talk for about 30 minutes and 30 to 40 minutes, and then leave it open for question and answer after that. And so the talk itself, I'm going to divide up into 4 parts so that there's no surprises. The first part is that I want to talk to you a little bit about where economics was during the AIDS pandemic, particularly in the late 1990s. And I want to talk to you about the way that economists were thinking about it and what that sort of discussions were like. And then also talk to you a little bit about what development economics, particularly the work of Amartya Sen, and how that sort of evolved during that time. And in the second part, I'm going to talk to you a little bit about the argument that I developed about thinking about health as a capability or health as a freedom. And then the sort of third part of this talk will be about our current pandemic and showing to you what the difference is between thinking about health in terms of commodities or capabilities, and how many rich countries are very focused on capabilities, and how that actually shows you that whether they like it or not, they were focused on capabilities and not commodities. And they were not interested in maximizing or cost efficiency. They were interested in something else. And what this shows us regarding the future and how this can influence South Asian health policy in the future. So if you'll allow me, let me begin just by sort of jumping in right away. As I said, the first part is that I want to take you back to an earlier pandemic. I know that many people in the news and headlines keep saying, oh, the last pandemic was in the 1920s and it was the Great Flu pandemic. But I think that that really is quite an amazing sort of kind of, I don't know how to say it, a dismissal of a pandemic that happened from the 80s through very much still today, which is the HIV AIDS pandemic, which has killed, over 20, 30 million people over a period of time. So it's just a very interesting way that people have understood what a pandemic is that they think that a pandemic is somehow, if it affects them or someone like them, then that must mean that it qualifies as a pandemic. But if it doesn't, then it's not. And I think this is something that is an important thing that influences future health policy as well. But so going back to the mid 1990s, what we saw in terms of economic thinking, and I want to point towards two important texts. One is that there was a publication put out by the World Bank in 1998 that came out after a number of years of shorter papers that was edited and written by one economist and one demographer. One economist was Margaret Ainsworth, I believe, and then the demographer was Meadover. And the book was called Confronting AIDS. And it was considered to be a very important publication because it was one of the major and first publications that a World Bank, which is ostensibly an economics organization and a finance organization, dealing with a health crisis as a pandemic crisis, rather than sort of regular immunizations or regular health policies. It was sort of dealing with a pandemic and epidemic. And what they identified over a number of papers beforehand in the book is that the HIV/AIDS epidemic, was a real concern for development, particularly in sub-Saharan Africa, because of a number of characteristics. One is that every HIV infection was a fatal infection. So it was 100% fatality. So this was one concern, is that unlike other infectious diseases, which have high fatality, it doesn't have anywhere near the fatality rate of HIV. So this question is that HIV is very different from other infectious disease because the fatality is very much certain on something like that. The second part that they identified is that this infectious disease affects the adults in the population because it's largely a sexually transmitted disease, and it's affecting the people that they consider to be the most economically productive. So the idea that this particular infectious disease was affecting working age populations, and therefore this was quite an important facet of the development picture if this was going to affect it. The third part that they identified is that aside from just being a health issue, it was going to have lots of social and economic consequences. So the idea is that there's a lot of knock-on consequences aside from just being a biological threat. And the fourth facet they identified, which they thought was really important, is that HIV was affecting the elites of a population. So unlike, say, another infectious disease, which might affect the poor in a population, HIV was affecting an elite. And so these four characteristics of this particular infectious disease epidemic, they said, was tantamount to a severe developmental crisis in sub-Saharan Africa. It was going to affect not only life expectancy, not only in terms of medical issues, but also it was also going to affect the long-term development of African countries. But what's so interesting, and what I really want you to focus on, is that the way they used economic analysis in order to reach a very particularly problematic conclusion. In this report, which is quite thick, it's about 400 pages, their conclusion was African governments, but also any low and middle income country, particularly low income country, should not spend money on AIDS treatments, but rather should spend money on prevention to a reasonable extent that's proportional to the need in the country. So what they did is that they posited a trade-off. They said, if you spend lots of money on AIDS treatments, then that means that you're not going to have money for other social goals. In particular, they put a trade-off between spending money for AIDS treatments versus educating children, which they thought was a key input into development. Is somehow this is the, as you know, I forget the name of the Chicago economist who sort of sees human capital as being an important sort of model in a way to think about social development. And so educating children turns out to be one really important investment that you put into the further social development of your country and the economic development. So this human capital model. And so the trade-off was treating patients with AIDS with drugs, or you can invest in children. And I want you to really think about this, because they were making this argument in confrontation or in contrast to the political and advocacy for ensuring equal access to drugs around the world for AIDS, right? So many of the AIDS activists were basically arguing that now that in 1998, this was sort of after the highly active antiretroviral treatment, or HAART, was discovered, this triple combination therapy was able to sort of maintain and mitigate the AIDS sort of conditions within a patient, but they were expensive. And many advocates were arguing that everybody in the world should get access to these drugs, not just the rich countries, or not just the people in the rich countries. And as a result of the huge cost of these AIDS treatments, these economists and demographers at the World Bank were making an argument that you shouldn't spend money on people who were going to die anyway by giving them AIDS drugs, that you should somehow spend it on prevention to prevent more people getting infected, but also to put money into other investment, public investment, so that you can sort of see the benefits of that. So I think that this was a really, for me personally, this was a very important publication. And I also had a chance to attend a seminar at Harvard where I was studying, where they presented this report. And I said, this is quite a problematic sort of conclusion on this, but they saw this as being a justified and economically rigorous and demographically rigorous and justifiable conclusion. The other important economic concepts that you will recognize that was applied to the AIDS epidemic was, one, the concept of negative externalities. The idea is that there is a role for public intervention into the AIDS epidemic for these reasons. One is that in terms of externalities, a government should sort of step in when there's negative externalities. And the idea was that people who were having sex without a condom and potentially spreading the infection did not consider their sort of secondary effects, and therefore these externalities, and therefore the government should step in order to do something about that. The second one is this idea of public goods. And so the argument here is that government should step in to provide the public goods related to HIV/AIDS, such as information, because the private sector would not find any incentives in order to provide these things, and therefore the public sector should provide it, and they sort of see that. And I'm just sort of pointing that out, is that public goods is contrasted between private sector involvement, not for any other reason. So the idea of a public good is something where the private sector doesn't meet it or does not provide it, and therefore it becomes a public good. And so it's a weird way of thinking about public goods, but I just want you to sort of understand that this is what was posited then. And the third sort of part was that there's a role for government to play in redistribution. And that is that because people who were being infected with HIV and would go on and live with HIV or sort of suffer from it, and their families would suffer, that somehow there is a role for government to redistribute. And so that is, in order to provide any sort of support or care for these people, this to them seen as a redistribution act, and therefore the government is a necessary actor in sort of providing that redistribution. So in the face of negative externalities, in the face of public goods, in the face of this redistribution, the government should step in. And at the same time, there was this other position that it actually shouldn't pay for drugs for treating AIDS, but actually should focus on prevention in order to sort of stave off any further deaths of people from AIDS. So I hope that I've been fair in describing in what the situation was in the way that, the World Bank was presenting it, and two eminent sort of economists and demographers were presenting the choice of what to do. I found this profoundly unsatisfactory and quite disturbing, I think. And I think, this was one of the questions is, how do you respond to this kind of analysis? What is the way to respond, and what are the different ways of doing it? Now, my work at that time was in human rights. And so I came from the world of this idea that, every human being has some basic entitlements that we have globally sort of agreed on as being some sort of basic entitlements. And it's also something that we have in the law, particularly international law. And so working at Human Rights Watch, my argument is about enforcing these rights. So what this shows is that if I were to present the rights approach to this, they would, from an economics point of view, simply say that rights are rhetoric, that they're not really meaningful, and in fact they're bad economics, right? So the argument here from the World Bank in this report is that the reasonable, rational way to think about responding to the AIDS epidemic is in this particular way. And therefore, to make an argument that say people have a rights to AIDS medications is an irrational approach, and it's sort of not cost efficient and goes against rationality and reasonableness that we argue in economics. So that was the sort of environment in the 1990s, late 1990s, that we were trying to deal with. At the same time, in 1998, I think it was 1998, 1999, Amartya Sen got a Nobel Prize, and he published a book called Development is Freedom, which essentially summarized a number of arguments that he had been making over a decade or 2 decades or more. And at the core of this book is this argument that development should be seen not in terms of aggregate numbers, but particularly not in terms of commodities, right? So what we should be looking at is that we should be focusing on well-being of people rather than whether sort of a certain amount of GDP was existent and sort of various kinds of commodity holdings, especially looking at aggregate numbers. So what he was saying is that if we want to focus on how people are actually living and what's happening in their lives, we should be thinking about their well-being. And he particularly made an argument that we should be thinking about well-being in terms of capabilities. And the idea of a capability for Amartya is this idea of a freedom, right? So it's not the same as a capacity, which is that a lot of people, when they think of capacity, think about it as individual capacity. So in terms of what am I able to do in terms of my body and sort of my brain, that sort of capacity as an individual person. But the concept of a capability is both what it is that sort of is jointly within what I internally have, but also my environment also provides. And the combination of these two things makes someone capable of doing something or not. And so his argument was that we should be thinking about development and social progress in terms of capabilities of individuals. And we should be focusing on this in terms of a variety of different kinds of domains that we care about. So whether it be literacy or health or political freedoms and other kinds of things. And so the question for me was, how do we reconcile these two different conversations. On the one hand, you have an argument that basically said that millions of people are going to die from HIV/AIDS, but we shouldn't spend money on treating the people because that, in a way, is wasting public resources, and also we should be investing in children. And on the other hand, this argument from Sen that's basically arguing that every individual has a moral entitlement to basic freedoms or capabilities, and so health is an important one of them. And so how do we bring that together? So that is really kind of the world that was in the late 1990s when we were going through a pandemic, an AIDS pandemic. And it wasn't, as you all probably know, is that in many rich countries, this was thought of as a homosexual pandemic, so something that was only affecting a minority of people and not really the majority. So it wasn't really something that many people took for granted. But it did become an issue by early 2000s because it was very clear that most of the world was suffering a heterosexual epidemic, which means that it wasn't just homosexuals in LMICs that were affected, it was also heterosexual populations. And this was going to impact economy and social stability as well. So in the following decade or so, what I have done is try to bring together different fields, trying to make an argument that would be coherent across different disciplines. So one was that how do we think about this idea of capabilities within political philosophy? And this is a lot of the work that Sen and Martha Nussbaum have already done in terms of looking at how we think about theories of social justice and theories of well-being, and how we can make an argument for focusing on capabilities rather than utilities or liberties or basic needs or etc. But building on that, what I wanted to say is how do we think about that, particularly in the realm of health? But then also we have in the field of epidemiology and public health, many people are really focused on disease control, disease prevalence, healthcare spending, et cetera. So how do we make an argument for the capability concept in that? And then also I did a little bit of sort of work in health economics, because this question about that it's irrational to talk about rights in economics, but also in health economics, particularly, I think was something that I was very sensitive to. So the argument that I developed, which is sort of essentially an extension of Sen and Nussbaum's capability approach, is this right to a capability to be healthy. And this is a very particular articulation of this right, because many people think that, oh yes, right, so health capability is really important. And so what we really need is health care to realize this health capability. And I think that this is a mistake to only think about health capability as just being health care. And I will bring this in later in the pandemic situation. But what many people do, particularly in the United States, where the conversation is still about providing everybody access to health care, is that because it's such a large country that dominates scholarship, that their concern about providing access to health care has become sort of the dominant conversation about health itself. But if you sort of work in countries in Europe or in the UK, where everybody does have access to healthcare, you realize that healthcare is just one component of actually the inputs that is required for people to be healthy. Right? So the second move that some people do is that say, okay, you're right, it's not just healthcare, it's public health and also all the different kinds of research that is used in stuff. So it's a little bit like healthcare plus, right? So aside from healthcare when you are sick and you get it, but it's also public health, which means that you need vaccinations and preventative healthcare, and you need different kinds of sort of regulations that protect you from, infections, food quality, workplace quality, et cetera. And then also biomedical research that sort of tries to identify solutions to something like that. I think that's better, but it's also not good enough when I think about what I mean by health and the capability to be healthy. What the argument that I put out is really based on decades of research in social epidemiology and also my work in HIV AIDS, which is that if you actually try to understand why HIV AIDS spread so quickly, it's not just about a virus entering the body of an individual and whether the individual can sort of use a condom or not. It's profoundly mimics and follows social inequalities in a population, but it also very clearly shows you that there is only so much an individual can do regarding their body and behavior to protect their health. There is a great amount of social conditions or circumstances that determines who is vulnerable to, say, an HIV infection and who is not, right? So whether you're a sexual minority, whether you're a poor woman, and whether you do sex work, or whether you're reliant on different kinds of sexual relationships to survive, whether you are a person that's so poor that the only thing that you can do is sell your blood because that's the only thing that there is for you to offer. So these kinds of structural and social conditions essentially determine who's going to get infected with an infectious virus such as HIV or not. So really, what I'm making an argument here is that a person's capability to be healthy is not just access to healthcare, not just access to public health, but really the surrounding social conditions that determine their ability to protect themselves and be healthy or continue to be healthy or not. And this is what social epidemiologists have been arguing for decades. And now increasingly, you will see that people in America and other places are suddenly using the word social determinants of health, because they're suddenly realizing that large social structural things like economic policies, racism, gender inequality, employment policies, all these different kinds of things actually structure vulnerability in a population towards disease or health. And these are quite distribution. So to me, a capability to be healthy captures all of those factors. And what we want to do is not just provide commodities, but we want to ensure that people have sufficient capabilities in order to be healthy. But more importantly, the really important thing for me is that aside from being able to be coherent, say I can make an argument for a capability to be healthy in a class of epidemiologists and social epidemiologists or public health people, but I can also talk to a political philosophy class about why this makes sense, and also a little bit to economists. But the fundamental foundation for this argument is the notion that every human being has a moral entitlement to a capability to be healthy. And this is the real kind of juggernaut, because for economists who seek efficiency, they find that kind of notion of every person has an entitlement to be sort of something that paralyzes their analysis, because you can't meet everyone's needs, and therefore what else is there to say? You can't do economics if you sort of try to hold everybody's basic entitlement to fort. And I think this has been one of the places of misunderstanding, but it's really important in the future, is that if you don't have any space to acknowledge that everybody has a moral entitlement to basic freedom or capability to be healthy, then you're obviously going to try to go for maximization, or you're trying to sort of say, well, we can't reach the worst off for a variety of different reasons, et cetera. But to me, that's a really important foundation, is how do you recognize and acknowledge everybody's moral entitlement to this kind of basic freedom? So to move on to the third part, and I'm happy to, in the Q&A, if you have any further questions about that, I'm happy to answer about that. But the idea is that, fast forward a number of years, and we had Ebola, we had Zika, we had sort of avian flu, all this kind of stuff. But as many of you know, is that these were considered to be sort of epidemics over there not affecting us, and they're really small outbreaks, it's not going to affect. But this pandemic has really been something that's, for a truly global pandemic, in a way that's a shared experience, unlike anything that we've seen. Perhaps some people say, oh, it's like September 11th, as if September 11th has affected everyone. But it has that kind of feeling that we all have some sort of memory and experience for it. But I think that there's nothing like this in modern times, where everybody truly in real time was feeling similar kinds of impacts of what's going on. And what I want to point out is that, prior to the epidemic, if the conversation about universal access to health coverage, et cetera, was still focused on commodities, right? It was still focused on how much healthcare can you provide a certain population? What is the package of healthcare that you provide? What are the kind of services and who's going to get it first? Those kinds of questions. But come this pandemic, in the richest countries, what you will find is that in the absence of a cure for this sort of virus, but in the absence of a vaccine, what they did is implemented a variety of what people call non-pharmaceutical interventions, which meant that people were required to stay at home, and they were supported through various kinds of income subsidies. The government made sure that the water and electricity and garbage was picked up, that the services were always stuff, and then people essentially were worked from home or didn't have to work, and they were given money for not working for a number of times. So that is essentially supporting the capabilities of people to be healthy, right? As opposed to saying, how much money are we going to spend on healthcare in order to protect people from the SARS-CoV epidemic? So de facto, the richest countries have already recognized that to be healthy is not just to have health care, but these supportive social conditions in order to protect you from threats, but also enable you to continue to live at least a basically decent life as you deal with this epidemic. That is essentially what happens during non-pandemic times if you are rich and middle class, is that the environment supports you in being able to be healthy. And meanwhile, lots of other people are not provided the additional kinds of social conditions they need in order to be able to have a decent, flourishing life if they are impaired or if they are in vulnerable population. So this, in a way, is, for me, a fantastic evidence of why we need to be talking about health capabilities rather than health commodities and health care. And I'm not saying that healthcare isn't important. The vaccine is a profoundly important commodity that is an important part of building people's health capabilities in this context. And we also need to be aware that you need masks, you need PPE, you need oxygen tanks, and you also need all these new treatments that come out. Those are all components of being able to help people stay healthy and live good, decent life. But all these other conditions in terms of, social security provisions in order to ensure that people who are disabled or extra vulnerable are given extra help, people who have to go to work because they're essential care workers are given extra masks and are made sure that they're given extra tests, etc. But a lot of that stuff needs to be done. So I focused very much on rich countries, but as many of you know from the South Asia region, India didn't provide any of the social support, but it did in fact just do the lockdowns. And what this did is essentially provided the middle classes and the rich with protections, while millions, if not billions, hundreds of millions of people just simply didn't have neither the ability to protect themselves from the infection nor access to the income and physical security they need to be able to live in that. And that, I think, is one of the most horrendous sort of injustices of this situation. And it was done in the name of science, right? Which raises this other question about what kind of scientific advice and policy is being applied. Can you apply a generic rule from Geneva and sort of ask for us to apply it equally around the world? What sort of ways that we could sort of think about it? Now, the second thing that I want to say about this pandemic, and I think I don't have to sell you this argument about capabilities or commodities. I think all of you get it very easily about this pandemic, how that happens. But the second important thing I want you to focus on is that this pandemic, this health crisis, could be and could have been an important opportunity for improving social equity, right? So we could have made this, and it's such an important way in which you reduce social inequity by ensuring that the most vulnerable people in our populations in our countries are protected, and you could actually use it as an opportunity to build social cohesion in a country. So one very good example is this idea of during World War II in the United Kingdom, that there was limited amount of food, and the way that the government dealt with it is that it provided ration cards so that everyone in the country had actually had equal amounts or sort of adequate amounts of food, which essentially prevented massive malnutrition among the poor, and also showed that children were able to get the basic nourishment, so their development isn't stunted, etc. So that kind of idea of bringing together a population that, in order to prevent social inequalities, massive distance could have been this stuff. But this could have been a very important opportunity for many LMICs, including India, to really redress the great inequalities, but instead they did not. Right. So in fact, what we have is that we have a widening impact on it. So looking forward, I think that we have a great amount of work to do. So what you will see is that because it was not about low middle income countries and their health crisis, you don't see anyone talking about negative externalities during this pandemic. No one is talking about, oh, look, those people who are not wearing masks are creating harms and it's a negative externality problem. You don't see any argument about public goods and we should let the private sector sort of work as much as it can while the public sector works. And we don't see anybody talking about sort of redistribution, right? No one says redistribution. They talk about support and employment support programs, et cetera, et cetera. So I want you to really focus on the kind of dominant economic terms that we sort of are using, but also keep in mind, look at the enormous amount of public spending that has occurred in rich countries in result of this pandemic. The 60 or more billion pounds that have been spent on vaccine research, particularly in the UK, where one person was given sort of basically the credit card to the government. It said, go shopping and find all the vaccines that you can get. And also the employment support programs, et cetera, et cetera. And in the US, you have a similar kind of problems. So the idea of scarce resources suddenly wasn't a problem. It was sort of, don't worry about it, we'll be fine. So I want you to focus on the fact that we're not, nobody's talking about trade-offs very much in this pandemic. The rich countries aren't really talking about it. And so there's a real different kind of language that is being used. But we now have one of the biggest problems from this pandemic is what the head of the WTO and the IMF and the World Bank are calling the Great Divergence, right? So basically the richest people in each society are doing really well and everybody else is not doing really well. And the richest countries in the world who have both vaccine and fiscal space, as they call it, right? So basically money to spend, are the ones that are growing the fastest and are going to be able to keep moving. While the first time in decades, middle-income countries are not growing faster than rich countries. Right. So, and then what we see is that the debt repayments that middle and low income countries have to pay will be greater than all the money that they have made over the last few years. So the question is, where are they going to get this money and what sort of impact will they have? So, the impact on health of populations in low and middle income countries, particularly in South Asia, will be enormous and it will be long term. What we know is that in India, and I apologize to my colleagues in other South Asian countries that I have not paid attention to the data as much, is that right now the Economist is predicting that we are now at about 23 million deaths from COVID. This is 5 times the official statistics. So this is because the official statistics aren't good, and also because COVID deaths do not include all the other deaths that are happening. And The Economist magazine feels as though it has a very good confidence and confidence level and robust mechanism to be able to say that we're around 25 million, and we are still not yet talking about the deaths in LMICs over the next 2 to 3 years, because the vaccines may not come until 1 or 2 years from now, if they do. So the implications for not only health but development in LMICs is enormous. And India, it's incredibly traumatic. I don't know what the official statistics say, but what we do know is that a significant population in South Asia, in India, has died from COVID, particularly older people. And that's a different kind of equity that we can talk about as well. So the problem now is that you can rest assured that international organizations will start talking about rationality and efficiency very soon. They will start talking about how in this time of limited resources and recovery, where there's limited fiscal space, we need to really be careful about where our public spending should go. And therefore, we really need to be going back to health maximization and cost efficiency in LMICs, and how are we going to do that? So I leave you with a couple of words, is that we have been here before, is that in the late 1990s, when the economists were arguing against spending money on AIDS treatments, there was opposition to it. And one of the ways that we won that was to start sort of actually questioning the price of AIDS medications, right? So many of these assumptions are that the price is fixed, and therefore, we can only sort of pay that price or not pay that price. But alternative models on pricing and where we could get the same kind of treatments and access to commodities at a lower price is sort of one way that we got through that. But I really encourage you to be very courageous in examining the dominant sort of economic analysis that is coming around and will come around in the future, particularly as we talk about resilience and recovery in a shrinking physical space environment, and really sort of ask you to think about not just commodities, but also health capabilities, and how you can widen the scope beyond just sort of buying commodities, but actually enabling people to be sort of healthy, and what sort of circumstances that kind of things require. And lastly, I think that it's really important that you take this opportunity to question, the prevailing economic voices here. I think for some reason, I don't know why, but it seems like the IMF and the World Bank, et cetera, seem to be, on the side of the poor this time, right? They're all talking about, how can the rich countries need to put in money in order to sort of save the world from, sort of deaths from COVID vaccines, the global economy is slowing down, et cetera. So they're sort of on the altruistic self-interest mode, right? That somehow it's a self-interested altruism, that if you help poor countries now, it's going to protect you in the future. But I really, sort of encourage you to think a lot more about, how can we make health more sustainable in LMICs in South Asia? And how can we do that by not just buying, vaccines for malaria, vaccines for TB, vaccines for COVID, medication for this, but actually thinking about how do you make people resilient through enabling their capabilities over their own lifetimes. And that is a much sort of better way to think about health, sort of, health independence and sort of good health over the lifetime. Okay, so thank you very much for this really great and privileged opportunity. As I said, I haven't talked to economists for a long time, so it's really nice to sort of at least sort of get an audience or something like that. There's lots of other work that I've done in terms of how we can use the capabilities approach in health economics, particularly health technology assessment, and how do we offer that as an alternative to QALYs and DALYs. But I haven't talked about that today because that's very micro in terms of how do we think about health care technologies. I wanted to leave you much more with this idea of health capabilities and development. And I hope that that's been clear. So thank you very much.
Dr. This is really wonderful. I mean, likewise, we are also people who really listen to economics presentations regularly, and for young scholars like us to listen to this idea is the world is enlightening. I mean, I'm right now with so many ideas, and I written so many notes that I really have to go back and read a lot about health and health capabilities. So right now, I will keep my excitement down so that others can also ask questions and this thing. But so you can either make your questions in the chat box or raise your hands. But before that, maybe I will start with a small question that on something, because I can't stop my excitement. So one of the things that that happens that I am also researching on is the change from NCD. So there is this 2013 paper based in India by Subramaniam saying that jumping the gun, which is about the socio-economic aspects related to NCDs in India. Okay, so thinking of while hearing your talk, I was also thinking, there is this even pre-COVID, there was this big discussion about India to move from communicable diseases to non-communicable diseases, etc. Which when I read from your lens, so I also feel that there is also a question of health capability there, because if you look at who are these people with non-communicable diseases, these are richer states, richer set of people. These are so even the whole discussion about moving from one health policy to another is often guided by this idea about health access and health care rather than health capability. So in a country like India, we are not done with communicable diseases, but the discussions are now really going to the NCDs and aging population, etc., which is really focused on certain set of people. So that was kind of thing that was recurring in my head, and maybe a slight comment from you, and then we can take to other.
Yeah, I mean, I think that the situation in India is that everybody has a claim on our attention, right, in terms of thinking about their health concern. So you might have very rightly a kind of commitment to helping the worst off, whether they be poor, socially marginalized. But there's also other people who are in the middle classes who are suffering from poor health as well. So I think that it's not a infectious diseases versus communicable diseases. I think what you'll find is that some of the similar social circumstances that are affecting the poor are also affecting the middle classes with their communicable diseases, right? So, in terms of the food quality or lack of open spaces or transportation, air pollution, all of these are sort of conditions that impact everybody who's living together in a society, and they have impact both on communicable and non-communicable diseases. So I think that you're right in saying that there is a bit of, the rich countries are moving towards a communicable disease agenda, and so should we. But unfortunately, in India and South Asia, we now have two problems, both of them, right? So we have both communicable diseases and non-communicable diseases. And we also have other things like road traffic accidents and injuries and all these other kinds of high prevalence of those that are well. So if you go from just, if you move away from specific interventions, like we're going to cover diabetes, or we're going to cover malaria, or we're going to cover TB, and start thinking about capabilities, you'll find that there's different kinds of policies that impact across the population rather than very disease-specific programs that will only impact certain groups of people. So I encourage you to think more about what are the big policy levers that could impact all the people rather than just some specific people with certain diseases.
Satvik, over to you. Your question, please.
Thank you very much. And I truly believe in your thesis on application of capabilities approach in health. And I believe in the theory, capabilities theories, of course. But it seems that after pandemic, the mainstream economics might consider capabilities approach is more useless, in the sense that you see, rich can become richer without sharing anything, without sharing vaccine with the rest of the world. Even in countries where social protection didn't stop reduction in the consumption of basic commodities, they are also rich become richer. And the financial instrument is as such that one can become much more richer even without any consumption taking place. So in all respect, it seems, I'm a believer of capability approach. I have written on it in my limited way. It seems it can be rejected. And those who have rich and powerful, they don't want to share, right? So which direction we can go? It's becoming very harder to sell again. Thank you, sir.
Yeah. So I think if I understood correctly, is that in a world which is most aligned with wealth creation, and if the most wealthy are accumulating more even during a crisis, what is the opportunity for us to implement a more equity or egalitarian policy towards health and in general social policy? I think that it really depends on a number of sort of potential things at play. So one is that it's very much about the social value of equity, whether in sort of realist politics sense, whether the middle classes feel that they're losing out on something from this current situation or not. And if they feel that they're not losing out, then we might not have very much to change. But what we do, I think, have is the idea that there is very much a growing recognition of the interdependence of our health. And this is what I think is a key difference between the AIDS epidemic and this pandemic, is that almost everyone around the world now understands that their health is interdependent to that of their neighbor or someone on the bus or someone far away in another place in another country. And so the less healthy that another country's population is, or the less healthy that people on the bus are, the more risk that we have in terms of our own health. And in India, I think one of the situations is that there's so much mixing between different socioeconomic groups. So people come into their house to do various kinds of functions. And while people think, well, I'm safe because I'm rich, is actually they're very interdependent on people who are actually not very well off. And therefore they're realizing their own vulnerability as well. I think those kinds of recognition of interdependency is one opportunity to talk about the future and health, and sort of saying, you will not be able to sort of think of yourself only as an island. Neither can an individual or a family or a class think of itself as an island, that there is actually health interdependency, nor can a state or a government or a country think of itself as being an island when it comes to health, that it's actually interdependence. And the second thing is that I think that much more needs to happen around social mobilization of the vulnerable groups from this pandemic, is that there hasn't been, because one reason is that a lot of people that have died are older people. And so they haven't been sort of very active or advocated for their interests. And I think that this is one of the places that we could see a lot more activity on something like that. But I think that you're also asking is a question of strategy, right? So it's also very much like, what's the strategy here in order to be able to do it? And I think each country has different political situations that require different strategies. But the idea is that what we're trying to all do is ensure that everybody has that sort of access to health or capability to health that we want to push forward. There are sort of various, and I'm sorry to ramble, I see there's one hand, but there are sort of definitely economic questions to be answered, right? So you can actually show, what are the different kinds of benefits for doing certain kinds of policies that we think are equitable and egalitarian, that are in the self-interest of the rich and powerful. If that is a way that you're willing to devote a year of your life to, is to commit yourself to saying, I'm going to show this answer that sort of is going to convince people that they should really be more equitable and egalitarian. I don't have that patience, but some people do. And so, but I think that that's stuff. So I'm sorry to the person raising their hand. I think it's Suresh. I see your hand up. Do you have a comment or a question?
Yes, sir. Am I audible, sir?
Yes, you are.
Yeah, I have 2 points. So it's like maybe observations. Like one is with respect to the data. I think you are also mentioning somewhere about data. Even in India, like there, we can see that there is an under-reporting of cases as well as the deaths also. That is one thing. Another thing is like, if you see the number of cases and number of deaths all over the world, we see that majorly the developed countries like US and UK, there we have seen number of cases are more as well as the number of deaths also more as compared to the other countries like China or Japan. So why this is that much disparity between those? And another area is like another one I want to ask is like this virus is actually mutating. Like maybe this biologist will tell more about that. And the vaccines we got, so we can see that the vaccines are maybe useful for one variant. So now maybe I think we are getting the news that in June or somewhere we are getting one more wave. So is this like softwares we have to update like once it expired or obsolete? So is that, so what will be the impact on our health?
So brilliant. I think those are really good questions and sort of thankfully easy for me to answer. So the first thing is that, your question is, why is it that the US and the UK have such high mortality compared to other countries? And you gave the example of China and Japan, et cetera. So the first thing is that I would be careful about the Chinese data because we don't know, and Chinese data tends to be unreliable, but I think that that's one place that we should be sort of, looking at, but be skeptical about what's going on. But nevertheless, I think your question is really good in terms of Japan, South Korea, Taiwan, etc. And I think what you will see is that even Japan still continues to have very much policies that we would talk about in terms of capabilities, right? So what it's saying is that, you must, if you enter the country, be in quarantine for a significant amount of time so that you do not spread the infection. And so they're very much on the conservative side in terms of risk management, and they want to make sure that people are continuously tested, that they are stuff. And then also the social values in Japan, there's a great amount of idea of conforming with social norms. So you don't want to be the outlier on the train who's not wearing a mask, right? So everybody's wearing a mask, so you should wear a mask too as well. And so there's a great amount of social values that resonate with this idea of protecting mutual health and community health, and not being that person who's creating negative externalities as well. In the UK and the US, what you had is a bunch of the US case, you can explain that differently by breaking down by states, and you'll see mortality has been higher in certain states versus others. And this somehow lines up with political allegiances. And the political allegiances have lined up with different kinds of protection and prevention efforts and programs. So if people are from states where it was considered to be un-American to interfere with people's behaviors, so asking people to wear masks or stay home or do all this stuff was considered to be violating basic liberties, rather than being sort of presented as sort of enabling people to stay healthy, right? Then you'll see that that's where the mortality is very high. But also in the US, you have a history of great social inequalities that show up in underlying health conditions. So the great mortality that you see even in the kind of liberal states is from minorities, and particularly Black Americans who've had poor health for a long time because they do not have access to healthcare, but they also don't have access to the good conditions for health. They've sort of experienced racism, but poverty, material sort of deprivation, et cetera, that led them to have great number of underlying conditions, which then compounded by COVID resulted in their deaths. And in the UK, it's pretty much the same story as well. And there's been some phenomenal sort of misjudgments regarding nursing care homes. Lots of older people die. So I think it's about 70% of deaths in the UK have been among older people above 60. So there's been a huge neglect and sort of abuse of older people in terms of their premature deaths in the UK and also in the US as well. So I would say that those would be some of the reasons why you see a difference between that and in Japan, where older people are protected very much and they're very, very sort of in a completely in different kind of sort of approach than they do in the UK and the US. In terms of your second question, I think the question about vaccines is that, it is very much like software. And I think you're right, is that, but think about how many vaccines that you've had when you were a child and how many rounds you needed, right? It wasn't just one shot that sort of took care of everything. You actually needed different kinds of booster shots. It's a similar kind of thing. But what we have here is that we are living through a situation where the science has to keep up with the evolving variant. But the important thing is that the variants only come about if people are unvaccinated. And so the reason why there's more variants is because there's millions of people who are hundreds of millions of people who are still not vaccinated. So our need for new software is very dependent on the level of unvaccinated people in the world. And so that's a policy decision, right? That's not a natural situation. And so the future really depends on our luck and our tolerance for the risk of sort of allowing for new variants to happen, and whether we can come up with a new vaccine that somehow will be protecting against all variants. And this would be the dream for rich countries, is if you can get a vaccine that protects against all variants, then you don't have to worry about vaccinating anybody else, right? You just keep going on to your own sort of life. So thank you.
Yeah, we are well surpassing the time that we have asked.
Okay.
Dr. Sridhar, but I hope you don't have any other appointments on this time. So any more questions? And I'm sure we have many more questions and discussion to happen. We will continue that. You can mail to us, and we will take those questions to Dr. Sridhar. Stay tuned to our for the health economics and policy in South Asia column for a recording of this talk, and also for the information about the upcoming talks. But I really want to thank Dr. Sridhar Venkatapuram for really taking out time to talk to us young scholars here in South Asia. And we are really enlightened and privileged to listen to your talk. We hope that we can continue this association that you have with Young Scholars Initiative and with South Asia Group. And we will benefit from your expertise in future also. Thanks a lot for taking time to come to our initiative.
Yeah, absolutely. No, thank you very much. It's quite a privilege to talk to you all. And as I said, I wish you much courage. And so in sort of looking at the things that you think are taught to you as being basic and fundamental, is that you actually need to look at those and see if there's other alternatives and other ways of looking at it. But most importantly, I really want you to focus on this idea that every person has this moral entitlement to sort of health capability, and how can health economics and economics more generally be recognized, that sort of moral claim. Right. So thank you very much, and I'll see you again.
Yeah, we'll stop the recording right now. But if anybody want to stay,
thank you so much, Dr. Sridhar. Thank you.
We can have a few minutes of informal talk if people want to stay, but we'll stop the recording right now.